Good afternoon and welcome to this No Fear Work Package 4 webinar. New COVID-19 wave, what has changed from previous ones? So before I start, I would like to say a very special welcome to two very special guests that we have today. From, on one hand, Ms. Gwendolyn Pang, the Deputy Regional Director for Asia Pacific in the International Federation of the Red Cross and Red Crescent Societies, based in Kuala Lumpur. Gwen, thank you so much for joining. It's very late for you.
Yeah, thank you, Harit. Thank you for the invitation. And also, I think it's good to recognize your work too in this field. Thank you.
So it's important to recognize the work of all the volunteers of Red Cross all over the world, really working in very specific and complicated situations together with many healthcare workers in the world. So we have from one end the IFRC from Kuala Lumpur, and from the other end, Joe Lamana from the HHS, that please correct me if I'm wrong, it's the Human and Health Services Department of the American government from Washington, very early for him. So thank you for being here with us, a pleasure and an honor having you. And we should start. And I would start for those of you who are not familiar with the project. We are a European funded project under Horizon 2020 with the idea that we are coming from a very scattered and complex chain of actors when it comes to health and security related incidents involving academia, suppliers, hospitals, pre-hospital care, and pre-hospital care, just for the sake of the example, part belong to the hospitals, part belong to fire departments, part are volunteers, part are third services, as we call them. So we are fragmented. It's very difficult to create an overview of needs, gaps, and dialogue with us. And the European Commission created us as a project exactly for that. And Professor Francesco Della Corte, who is with us now, our beloved coordinator, presented exactly this this morning in a very large what used to be called the group of users, forum of users of the European Commission, DG Home, exactly talking about the focus that the project No Fear took during the pandemic to try and identify quick wins when it comes to pandemia. Our project is organized around three pillars: the acute care of patients, which our colleagues from the Catholic University in Rome, Policlinico Gemelli, are leading. Our colleagues from Crimedim in Novara are leading the training and education, and the Magen David Adom is leading the acute care operations in security-related incidents. Some housekeeping messages. First of all, is that we are recording the webinar. We will share the recording, and for those of you who agreed, we will share your presentations. And the most important thing is that this is not an institutional lessons learned exercise, by no means. We are not going through a formal process of lessons learned approval by our institutions. We are trying to do a quick and dirty sharing exercise, trying to share with our colleagues our lessons learned, lessons observed, I would say is the better term, so we can learn one from the other, especially during these rapidly evolving times of pandemic. We have a very long and distinguished list of speakers for today, so without further ado, I would immediately go to our first presenter, Cristian Calduro, from the Ministry of Internal Affairs and Department of Emergency Situations in Romania. I would just kindly ask the speakers to stick to their 10 minutes limit. Thank you very much, Cristian. Over to you.
Okay. Hello, everyone. Nice to see you. I hope everyone is okay. My name is Cristian Căldăraru. I work in the uh, Emergency Situation Department. I'm trainer in first aid and extrication. Also, I am assessor for war rescue organization. Next slide, please. Okay, I want to start and say everyone, this is a difficult time. We have a lot of stress, a lot of accumulation, a lot of frustration. Okay, I want first of all to apologize for my English. I hope everyone understand. Let me say you that from the very beginning, the Romanian placed a great value on the vaccination campaign, and a platform has been set up to organize this vaccination process. The way of working is very simple. The citizen create an account and can register up to 9 members. What is the improvement? Our government and our leader discuss the possibility for the possibility for a user to able to register an unlimited number of people. In this way, a restaurant owner, for example, can register all his staff to make sure they are vaccinated. This solution may help restart the economy. This is our point of view. Also, in this platform, there are useful tips, official information that the population should take into account during this period of time. Next slide, please. Okay, like most countries in the European Union, we stage the vaccination process in 3 stages. From the end of December until now, 2.5 million Romanians have been vaccinated with at least 1 dose of vaccine. At the moment, we are in stage 3. We make vaccination for general population. We are glad that a large part of the population is aware of the need for vaccination. Let me tell you that a lot of part of our population, our Romanian guys, are very interesting to make this vaccine, but we have some issues with a small part of our citizen. Next slide, please. Maintaining of the state of alert in the territory of Romania will also have some problem related to non-compliance with safety measure and suspicion regarding vaccination. We face a wave of protest in the big city of country where people did not respect safety measure, did not keep the physical distance, and shouted against the protective mask and against vaccination. Unfortunately, throughout the media coverage of a public figure blame safe measure and suspicion of vaccination, part of the population is become more skeptical and I don't know the word, irascible. Okay, sorry for the word.
Irritable.
Next slide. Okay, thank you so much. Next slide, please. As the president of the National Vaccination Community said, it is clear that we need a more explicit and active campaign to promote safety measures and to involve in public figure who explain the need and the benefit of the vaccine. But Every night in prime time on certain television, public figures are invited who criticize and any measure, and the worst thing is that they not come up with any constructive idea so that we can evolving for the better. I need to tell you something. We have a public politician in Romania who criticized the measure, criticized the vaccine, and unfortunately, a lot of citizens believe that it is the right way. We struggle with that. We make everything possible to tell them that this is not the way. The vaccine and the physical distance and the mask is the way, but we have some big issue in this part. Next slide, please. It is clear that the result of these public events where no physical distance is maintained or people do not wear a mask, it's felt in the large number of cases, and the worst in the number of cases that require ACU. There is a huge pressure at the moment on the emergency room and on the ICU. The physicians are exhausted, stressed, and unfortunately the effect of burnout occurs more and more often. I want to imagine something, all of you. Imagine that you are a doctor, a physician who has been treating patients with COVID for almost a year, and at some point, some citizen appear at the gates of the hospital chatting that you are a criminal. This happened in Romania. Our physician was in shock, and I am sure that the frustration and surprise will be huge. And I know this from my colleagues, and who do not understand this approach. There is also a beautiful part. This is a nice thing. We'll still have an active volunteer program among medical students who help in ICU, emergency room, and ambulance service. Their enthusiasm and desire to help is huge, and this helps maintain the fighting spirit and among the medical staff. Next slide, please. Taking account the large number of critical COVID patients and the declining number of the ICU free beds, one of the solutions found was the buy 5 mobile ICU unit with a capacity of 12 beds. Since there, we buy this ICU mobile, and until now, a considerable number of patients have been treated in these units. A huge advantage of these units is mobility. When a hospital for COVID is overcrowded and there are no more vaccinated, no more ICU bed free, this mobile unit can be placed in the hospital backyard, and after connecting to the hospital utilities, it can be put in operation. Next slide, please. The conclusion of my presentation was the vaccination is the key. We have a huge problem with burnout, and in my point of view, the role of the media is very, very, very important. And in the end, but not the last, the summer is coming. For medical staff, I believe and I hope to be good, but I don't care, and I don't. Sorry, I don't. I'm not sure about this, but let the time will tell us. Thank you so much. If you have questions, and sorry for my English again.
No problem with the English. We will save the questions to the end, and thank you very much. I think that the change in the mood of public and media is something that is worth attention, and our colleagues from Trilateral are already organizing a workshop on the role of communications during the pandemic. I think that would be a very valid point. Thank you so much. Peter, over to you.
Hello, everybody. My name is Peter Daly. I am currently the COVID project manager in the South-Southwest Hospital Group. We have 10 hospitals across the south of Ireland. Next slide, please. Okay, just to explain the COVID waves and how they occur, we need to note that Ireland is an island. There are 2 jurisdictions on the island of Ireland. One is controlled by the capital, Dublin, and the policy of the Irish government. The other is controlled by London and the policy of the British government. And the virus doesn't know that. And we also have the complication of Brexit. And one of the points I wanted to make was that there is a political dimension to how the outbreaks occurred in Ireland, both national politics and international politics. Next slide, please, Kaim. Okay, as I said, there's an international border between the UK and the EU. There's also, so when you see the map of Ireland, you can see that there appears to be no cases in the northeastern part, but of course they are. And we're currently, hopefully, towards the end of the 3rd wave. Our first wave was in mid-April. Our second wave was mid-October. And the 3rd wave, and you can see on the graph that the first 2 waves were gentle. We thought they were serious, but until we were hit by a 3rd wave. And that 3rd wave began on the 22nd of November. And we hope it's coming to an end. Okay, next slide, please. Okay, just to indeed, this is our 3rd wave. And if you look at the red line on the graph, that is the number of cases in occurring in Northern Ireland. And you can see they're ahead of us. And the point that I was making is that despite any attempt to, we can't close the borders between 2 countries. We can't close the border with the UK. Therefore, whatever happens to them happens to us. And you can see that our curve is after theirs. I'll be talking about the size of the curve in a second, but just to indicate that as it happened in the UK, then as a few weeks later, it started to happen here. Next slide, please, Kaim. Okay, this gives you a better idea of the 12 months of the COVID-19 in Ireland. We began with no cases, as in nice green island. We began to get a little bit red as we went through April, May, and June. It began to improve dramatically. And then in August, it began to get very good. But then you can see as it moved through October, November, and these are tiny maps of each county. And you can see by the height of the 3rd wave, we had COVID everywhere on the island of Ireland. And we were brought almost to our knees. In the hospital systems where I work, we had improvised intensive care capability. We had to stop everything else except that. And in the middle of all that, on the 29th of December, we had to begin vaccination at the same time. Next slide, please. Okay, and part of the reason why it got very difficult for us was because the the new variant arrived, the Kent variant. And you can see the list across England of where the Kent variant was. And Kent is in the southeast of England, London, Kent, London, and as it happens, Northern Ireland had the same level of incidence. And within a very short space of time, it began to literally burn through, it just completely took over from the original variant, and almost exclusively, 98% became the Kent variant, and moved very quickly, a lot faster and a lot more quickly than the first variant. The next slide, please, Kaim. Okay, now, partially it was our own fault, and again back to politics with a big P, meaning the Irish government's view of things. If you look there, you can see Christmas last year fell on the 25th of December. And you can see how movement we had. If you look at, we had, in early December, they allowed shops, hairdressers and gyms to reopen. Then we allowed 2 households. Then we had restaurants, gastropubs were closed just on Christmas Eve. But at that stage, it was too late. We had already taken off into the third wave, and it spread dramatically. In about 14 days after Christmas, you can see how the cases surged. And for those of you who are interested in the hospital side, the hospital was 14 days after that as well. Next slide, please. So you can see that the share of the cluster and the outbreaks in all settings between the first and the third wave. In the first wave, we had very few clusters in private homes over on the left of the graph. And yet around Christmas time, which is understandable in many ways, the bulk of the outbreaks were in private homes. Now, we had got the nursing homes under partial control with fairly strict kind of lockdown arrangements, and they began to work. So when you contrast then on the nursing homes, we had a lot more people, not more outbreaks in nursing homes in the first wave, and far reduced than other. And we had workplace, and we had travel related, and so on. So you can see the differences between the way the outbreaks occurred between the first and the third wave. And I think that's a lesson for the future. Next slide, please. Okay, now you can also see the number of deaths in the differences between the first and the third wave. Now, we clearly knew that death and severe reaction was age related, but you can see very, very clearly that from the 65 to 74-year-olds and up to the 85 plus, that is where the bulk of the deaths occurred in both waves really, but dramatically increasing in the third wave. And that's a question of the numbers. There was so much circulating in the country that it was almost impossible for these facilities to escape. We had huge numbers of healthcare workers that were affected. We had trying to operate. We have in Ireland, we have private nursing homes which are run on a private basis, and some of those literally collapsed because they didn't have the resources. So the state had to strip resources out of whatever other resources we have to try and maintain those facilities, rather than have large numbers of those patients come into the hospital system where the care they would have got was no better than the care they would have got in the nursing home anyway, with a high degree of care. Next slide, please. Okay, now there's a danger of too many statistics, especially when you're trying to brief the government or brief the management teams and so on. So if you have a kind of a parts of the country with very low populations, or you have a country which has a low population, showing everything in numbers per 100,000 can be quite misleading. Over on the west of Ireland, you can see I've put a blue ring around the part of the country that is very low population density, yet it seems to be among the highest places in the country. More significantly, we have other areas which are genuinely high, and one of them I've put a little ship to indicate that's one of the ports where there's a lot of traffic from the UK. And in one of those, there was a funeral that occurred just before Christmas, And from that, we had almost 300 cases, including the wife of the man who was buried on the first occasion. She died, and some of the family died, and so on. So it was a real tragedy, but it set off a burning in that part of the country that it just goes to show the travel it is. And you can see the huge cluster on the border with Northern Ireland. Next, so that's the danger of scale, that you need to be careful when you're briefing people. Next slide, please. Okay, this is pretty simple. It just says 87% of the cases occurred in those under 65. Yet this age group only occurred for 7% of the deaths. Yet on the other side, on the right-hand side of the graph, 13% of the cases occurred in those aged 65 or older, and it makes up 93% of the deaths. And we've using that fairly stark kind of statistical information to say we made a decision to vaccinate on age grounds, and also those who have underlying illnesses. And we're trying very hard to stick to it, but now we're getting into the vaccine envy and vaccine blackmail phase of our vaccination. But 13% of the cases occurred in those over 65, and 93% of the deaths occurred even in the second half of even in the third wave, when we were as strict as we could. Next slide, please. Okay, so that's our vaccine progress so far, controlled almost completely by the availability of vaccine, and then by the availability of vaccine classification as to who it can be given to and who it can't be given to. And for the politicians, again, it's a huge political issue trying to listen to demands for vaccination for various parts of the country. Yet on the previous slide, it was clear who was at risk and who wasn't. Next slide, please. Okay, that's a more realistic picture of what the country looked like right on the 24th of January, right on the top of the third wave. You can see you see one of the counties near the border is shown in a very dark color. If we look at the next slide, you can see that that county has now turned green on the 20th of April. And it's one of the counties, one of the 3 counties for which we've had no cases in the last 7 days. And you can see that the third wave of the COVID pandemic, which started on the 27th of November, is now coming to an end, we hope. It looks like, but it's so dangerous that it could take off again, with people saying it's over, the problem is gone. Okay, that's it for me. Thank you, Kaim.
Peter, thank you so much. I think that this, we call it in Israel, the feeling of the end of the training program.
Yes.
And we know how soldiers behave when they feel the training program is over. And we are seeing that in our society. And I think that that's really the great challenge that we will all be facing. And I wish you all the best with that, especially that summer is coming, as our previous speaker said, and people want to go to the beach.
Good.
Thank you so much. Uwe, please, over to you.
Hi, thank you so much for the invitation, and good evening, friends. Hello from Germany, from Bavaria. I give you the next 3 hours a short overview about the situation in Bavaria and Germany, what is ongoing. And you'll see on my next slide, that is the Bavarian situation. So we have 7-day incidents, around about 178. This is a very important figure. So this is in case all incidents about 100 have strict regulation from the government and jobs closed, schools, etc., etc. And we have what is a new situation combined to the long pandemic is we have more and more young patients between 29 and 15. And we have, and this is a good news, like also the Irish colleague said, we have no more outbreaks in nursing homes. Yes, this was a hotspot. We remember in the first
no fear webinars time. We had a very struggle at this point, and this is much more better. And the situation in Germany is marked on the next slide. It is also the red point on the graph. You can see it is more and more from an age, and so we have also every week is international and every day from the Robert Koch Institute. This is the numbers and figures where our government and the Chancellor will handle the situation and give the regulations in the local broad. So maybe this is statistic, you can see it also. And so the colleague from Romania, from Bucharest, told us, and it's also on the coming slide, is the situation of vaccination. So we have once on the left side of Germany and complete on the right part of the slide. And we think if we have more and more vaccination person or victim, so we have a lower problem. So this is a big discussion, as you saw it also in the other presentation. The big discussion is, can I have on which date at home my doctor, etc., and how it is structured. We have special centers set up all of Germany and have an online registration system. And some of the population is not so happy. It is a long term that everybody normally influence you go to a doctor and have your vaccine. So, but the task from KIND to us was to say in this presentation what change we have made in our response and what have we learned. Maybe we have learned something. And so I have a new SARS-CoV category protocol. Maybe is this for all organizations, for all rescue teams the same, and this category A, B, C, and D. And the nurse and the staff in the hospitals have a clear idea what he must order in a control room. And so all patients with COVID have special hygiene measures. We have also special protective equipment if needed, and also strict disinfection rules. And so what is helpful, so we have one protocol for all players in the field. And so we have learned in the past that is the most effective training is and standards is make it easy. And I have two pictures from an inside from an ambulance. And so we have standards for all patients with and without maybe COVID, also after an incident or a stroke, a heart attack. Every patient must wear a protective mask. It is reading very easy, but it is great effective and is also make his disinfection on a stretcher from his hand. So it's very, very easy to train our staff to understand. Easy things are very helpful to handle the situation. And so, sorry for that, we have no excellent trucks like Bucharest for mobile ICUs, and we have a system. And so the control room organization is as follows slide, is a globally concept. Globally means we have split Germany in different sectors like south, southwest, west, north, and east. And if one area overfull and no capacity, the doctor in chief say, okay, we transfer, maybe take an example, a patient of the area from the west to the south. So we move the patient, and we have in every county an over-regional control room. He will organize by helicopter, by a special care transport, etc. And so we have an opportunity and a tool to relax the situation in the hospital. So like the map from a colleague from Ireland, you see one part is very strong with COVID and the other one is green. It's not only one patient. And so it is one opportunity. It's important for us guests in the chat to understand it is not the best is what you help in your home state. This is for Germany a good opportunity to move the patient, to find more resources, and you relax a little bit the situation. And so it calls global leaf concept. It is the first publication about this, and it could be a good maybe tool to handle. What is all next problem or a special situation is a cross-border situation. We have different borders, maybe in view of Bavaria, we have Germany, Austria, and we have Czech Republic to Germany. And so it is different regulation. And so also it is also regulations for the Red Cross family. We have no separate standard, and it is also a problem that we have a cross-border mission, and what is ongoing or need you in testing or must go in quarantine and so on. What is the conclusion? And I come to my end time. I hope I'm just in time for this quick speech. And it is important to remind your staff, and I have the big picture from your rescue station in Tel Aviv times that the staff is a key, maybe also a part of a key, and they must understand that it is important to clean your hands, look for the disinfection every day, use your mask, yes, motivate the patient, yes, clean your hands again. And I'm sure if we have more and more vaccines and handle the situation, and I'm looking forward to also know dear friends to see it live and in color, like the German said, for the next great meeting. Time, thanks so much again. Thank you all. That's it. Question in the end of the session. Thank you.
Uwe, thank you very much for a wonderful presentation. I think you have highlighted something that I think we tend to forget in this pandemic, and this is the cross-border cooperation, and the fact that in some cases in Europe, the closest hospital or designated unit is across the border, and that you have mechanisms that used to work on a daily basis, and now with closed borders, it is a challenge. And I think that especially when it comes to a patient transfer, getting back to normality will take us some time, and getting ourselves reused to using those mechanisms. So thank you for bringing that up. Very, very important. Thank you.
Welcome.
Sophie, Eve?
Yes, thank you, Chaim. I will do the word. So thank you for giving us the opportunity to share the situation in Belgium and what Uwe just highlighted, and also Christian, you will see that there are some similarities. Can I have the first slide? This is from Cienzano, the National Registry Office, where you see in the middle the second wave in October, which was rather heavy, and then more at the right side you see the third wave now, which is in contrast to Ireland, a small wave, and we had a big second wave. But I will show you the challenges of that third wave, even if she is very small. Next slide, please. These are the number of patients in the hospitals. You see that first wave was in early of April, then the second in October, November, and then the third at the right side, just to give you an impression. Next slide, please. This is actually the testing and the positivity of the testing. It's a bit a crowded slide, but it's following the waves, etc. That's just to illustrate you. Next slide. And then we started also vaccinating people, and in a very, 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 very slow rate. We have now I think about 20, just above 20% of the population vaccinated. And there are differences between the regions, French-speaking, Dutch-speaking, German-speaking, etc., because there are a lot of political discussions, like Peter also said, it's politics with the big P. And so our vaccination pace is very slow. And so we hope now that in the next weeks and next months, and it's depending on the delivery of the vaccines, that we will increase that pace, because this is really, I will not say the solution, but a key in the attack of the pandemic. Next slide, please. And then I want to compare the situation we had with the third wave with something about acute cardiology. If you see a ST segment elevation, then each emergency physician should say, oh, what is happening? And we had an ST segment elevation early this year, but you have to go to the cath lab. You have to open the vessel. If you don't do this, you get myocardial damage. And this is what happened in the third wave. So next slide, please. I showed this one before in another webinar, I think end of last year, where we have a national surge capacity plan that was installed by the Hospital Transport Surge Capacity Committee from the ministry, where there is a certain degree of leveling and increase in percentage of ICU beds, etc. And again, when we started with that ST segment elevation, our government sent it out to each hospital this slide again and saying, okay, you have to go to phase 1A, then you have to go to phase 1B. And now we're at the right side of the slide. We are in phase 2A, where actually more than 50% or 60% of our beds should be ICU beds should be COVID reserved. And this is really what is happening now. There was a big fire in the beginning of the week in Brussels. Maybe it catched the newspapers abroad, where there was 30 victims, etc. And there was only one ICU bed available in the whole region of Brussels, which is really a catastrophic situation. So we started again to increase our surge capacity, and this I will come back on that at the end with the challenges we face now in that third wave. Next slide, please. A bit of the numbers of our hospitals. In the blue bars, you see the all overall patients in the ED in my hospital now, and the suspects of COVID in the orange. And you see nicely the first wave, the second wave, and then you see the third wave that is rather similar to the second wave. And but if you look at the blue bars, you see that together with that COVID increase of patients, you see also that our regular care is there, and that's the real challenge now, how to manage those two streams of patients. So next slide, please. So I had a slide in October 2020. You will probably remember what were the challenges and the new problems. This was in October, the increasing of the COVID cases, the ongoing regular care was there. We had reduced capacity on non-critical care wards, reduced capacity of ICU. There was a kind of central regulation of beds, but it was not efficient. So every hospital went into self-protection mode, and they said, okay, we will increase our surge capacity, but we also will keep on going our regular care, which is difficult to hold. And then we had boarding of sick patients in the ED, and we had also an increased sick leave of personnel due to infectious issues. So next slide. What changed in April 21? Maybe you don't see a lot of differences. And so what did we learn? Yeah, we learned that there are the same problems. And one only thing I changed in the last sentence is there was an increased sick leave personnel also, and I think, Christian, you mentioned it, due to burnout. People are tired of getting that third wave, and now hopefully we will not have that fourth wave and that fifth wave, etc. So this is similar what you see, and I can guarantee you our population is not wearing the masks, is not keeping the social distancing, so there are similar problems here. Next slide. Some new things, Chaim, to end, is that we are now confronted also with mixed flows of different patients. So we have patients that are non-vaccinated, we have patients that are partially vaccinated, and we have patients that are fully vaccinated. So this is the mix of patients coming to the ED, and so a different approach. What we don't see anymore, and this is in contrast to what Peter was telling us, all the patients coming from the nursing facilities, which were very badly hit in our first wave, we don't see them, because in the vaccination strategy that was installed by the government, all the nursing facilities were put in priority. And so we see now younger people. And what we see is now sick children. We see now the peak in RSV infections, what we normally see in October, November, January, etc. So our pediatric wards are also on a very high stress level of surge. And okay, a child who is coming to the ED with fever, it's COVID until the contrary is proven. So this is actually also on top of a challenge. Outbreaks in the hospital. We are all vaccinated, but there were some visiting rules that there were no visits in the first and the second wave. Then we opened a bit for the family. This brought in some infections. There were closing of wards. There was a reduced admission possibility. And this comes always back to the ED, because you cannot get rid of your patients inside your hospital. And we had boarding of patients. And together with now the pattern of the new patients, they are very, very sick. They are not older people, they are not younger people, they are all people of my age, between 55 and 65, and who need ICU. And we had a lot of more ECMOs that has to be placed to those patients, which not always a successful end. And then having said that closing of wards and already a surge capacity that is under pressure, what is also coming back to the ED, and unfortunately, Chaim, we don't have something like MDA for the inter-hospital transport also. We have to provide our inter-hospital transport ourselves. So if you don't have place to admit the patient, you have to organize your secondary transport to another. And so the secondary transfers to the other facilities now are very difficult, because the other hospitals have the same issue. So it's really sometimes 2, 3, 4, 5 hours on the phone to see where you can hospitalize the patient. So next slide, just to give you an impression on the numbers. It's in Dutch, but I will translate it. Aantal patiënten is number of patients. 306 is the number of patients we transferred from our ED to another hospital in 2020, and it was mainly, as you see on the right side, in the second wave. And I can say there that we had about 180 patients transferred in October, which was 1/5 of the total number of Belgium. So we transferred a lot. And if you say like, okay, it takes 2 to 3 hours for a patient to get transferred, you can count about how many man hours or female hours you invest on that thing. The next slide, and this I think is the last one, this is the number of patients we transferred now. In March, you see we are almost at 200 patients, where in 2020 we transferred 300 patients. Now we are almost 2/3 of the patients. So there is a lot of burden on transferring the patients from the ED. And I think this was my last slide, Chaim. Thank you so much for having me sharing those feelings from Brussels.
I can't hear you, Chaim. I don't know if the other one Same. I can't.
Sorry for that.
No,
Can you
it's
hear
okay.
me now?
Yes.
If I don't know, it will not make you feel better, but I can tell you that the whole month of January, all the patients from Jerusalem were transferred to Tel Aviv area hospitals because Jerusalem did not have the capacity to hospitalize them. You can imagine it's a transfer of 1 hour and whatever is associated with that. But on the good note, Paloma will let you know later that the WHO officially declared people younger than 65 as teenagers. So it's no longer patients our age. We are teenagers. Prepare the pediatric wards for us.
Thank you so much. We have still a future, Chaim.
Yes, exactly.
Thank you so much.
Catherine, another teenager in our group.
Yes, thank you, Chaim. I appreciate. May I have the second slide, please? Well, if you see the slide, you see the boat. And I must confess that the situation is not stabilized in France. Next, please. So what is the current health situation? We did not reach yet the peak of the third wave, despite deprogramming a lot of surgery and medical care. And we miss to treat current and daily emergencies. It's a huge problem because we have COVID patients and non-COVID patients to take care of at the same time. The number of hospitalization COVID plus is still increasing. And we are now filling 8,000 beds, and the top will be 10,000 beds. As you said, we have younger people. We also have pregnant women. And in ICU, we have about half COVID plus patients and half COVID, non-COVID patients. The problem is that we have no transfer possible due to the lack of ICU beds elsewhere in France. We have about the same situation, and families do not accept these transportations. The number of clusters in hospitals is high because the staff is contaminated. And COVID infection is the main nosocomial infection. And we have better capacities of sequencing samples, and we face 80% English variant, 5 to 6% South African variant, and 1% Brazilian variant. And this variant worries us. Next. So from Saturday, 3 April, curfew already enforced in some parts of France is extended to the whole of the country. And from 6 a.m. to 7 p.m., we must stay within 10 kilometers far from our home, except for some specific reasons, and we must carry an exemption certificate if we need to go further than 10 kilometers. And if we do not respect these rules, we may be liable for a 100 fine. But we have no policemen to do this. From 5th of April, we are not allowed to travel elsewhere in France without a pressing reason. So no vacation for people at Easter time. The national school calendar has been modified. Spring holidays run from 10th of April to 26th of April. It will end next week, wherever we are in France. And pupils will return to kindergartens and primary school next week. Pupils will return to secondary and high school beginning of May, with a mix of distance and on-site learning. And students may go on-site universities 1 day per week. It's not really a lockdown because people are encouraged to spend time outside, but we must not meet other people, no more than 6 adults. We do not eat or drink with other people, even outside. And we are obliged to wear a mask and respect the barrier measures. Next. So vaccination is our hope. So far, we have 10 million of people vaccinated with the first dose at least. Pfizer and Moderna vaccines are administered to all those aged over 70. Eligible for vaccination, people aged between 60 and 70 from now. And from 15th of May, people aged between 50 and 60. And mid-June, people under 50. By the end of the summer, it is anticipated that vaccination will have been possible for all French adults who want to be vaccinated. And of course, 20% of the population do not want to be vaccinated, especially with AstraZeneca. And health professionals are still reluctant to be vaccinated, despite the benefits. You see the graph on the right side of the slide. And of course, we had a very bad communication about AstraZeneca, and people do not want to get this vaccine. And the rate of vaccination is not optimal because of the lack of sufficient doses. Therefore, the government decided to postpone the second injection of the vaccine to 42 days, and for AstraZeneca, the booster at postponed at 12 weeks. 70% of medical staff is vaccinated compared to only 30% of non-medical staff. Next, so the issues. We have limited ICU beds, capacities in ICU beds. And we question the strategy because we tried to have some freedom, but it was not the strategy zero COVID. And actually, the staff is in burnout. The population is not trusting anymore the government. And we have a lack of visibility with a time factor that is becoming our enemy. And it's always a matter with the media of arguments between doctors and economics and politics. We have to train new staff and reinforce medical ICU capacities. And of course, we have a lack of human resources, and this goal is very difficult to attain. And we have two flows of patients, you know, COVID plus and non-COVID. And we have a lot of twin bedrooms in our hospitals. And sometimes, you know, it's a nightmare to know how to dispatch these patients. We are highlighting the dangers of aerosolization, and we add to the barrier measures the fact to be outside and to ventilate enclosed spaces, especially at home, because of course, like you said, we have a lot of contaminated people at home. And we have also an issue with borders, and we depend on European rules also. And we do not isolate and ask for strong quarantine measures to people coming from abroad. So that should be, that is a problem actually. So we hope that next week we will have the the beginning of the decreasing of the third wave. But for the moment, you know, the situation is not good. That's it.
Catherine, thank you very much. It's interesting to see how the fight between different societal values is always an interesting issue.
Yeah.
Economy versus health. A real question for the future. Paloma, over to you.
Thank you, Jaime. Good afternoon to all of you. And I wanted to show the actual situation of COVID-19 in Spain, and especially here in Madrid, and also to explain the changes we did have to do in the response, and those who will possibly remain for a long time with us. Next slide, please. The actual situation in Spain, as you can see in the graphic, we are in the beginning of the fourth wave. It seems like the third wave was the worst of them, but that's not true, because the first wave, the intensity does not respond to the official data, because at that time the government decided not to test PCR on the COVID suspected patients unless they were hospitalized. So there are lots of people who were diagnosed of COVID-19. The second part is divided into the second, third, and fourth wave we are on now, and they have more impact on the incidence than in the hospitalizations. Next one, please. In this chart, we can see the number of hospitalizations throughout the pandemic and the difference between the first part of the pandemic and the rest. The saturation of the hospitals in the first wave was such that most of the hospitals in Madrid became COVID hospitals. They weren't assisting patients with any other pathologies. The ICUs were at 250% saturated. All cardiology services, stroke units, and other wards had to be enabled like COVID ICUs. Next one, please. And the official mortality rate in Spain is around 77,000, but it's probably much higher due to the lack of PCR tests, as I already said, during the first wave. But this is the official rate up to date. And if we compare, next one, please. If we compare with other countries, we can see Spain is the 9th country officially in terms of incidence, and the 9th one in terms of number of deaths. So number 9 for us. Next one, please. And regarding the vaccinations, we did have what we can see is the last report released on April 16th that shows that 90% of the vaccines we received had been administered, and 90% of the population has the first shot, and 7% has completed the vaccination. Yesterday there was a new release, and there are little differences. 90.5% of the vaccines administered, 20.8 with the first shot, and 7.6 with the complete vaccination. So it's not a great difference. We have the same problem with AstraZeneca, people that doesn't want to be vaccinated, people who wants to choose which vaccine they have to have. So it's not being easy for us. Next one, please. And this is a curious thing, because if we compare rigidity in terms of containment measures, in Spain is one of the countries with the greatest flexibility. Although we have to say that this depends on different regions. In Spain, we see the strange case that we have 17 different governments of 17 different communities, And we go from the maximum rigidity of Valencia to the maximum flexibility of Madrid. Here in Madrid, life is practically normal until 11 p.m. with everything open since summer of 2020. And despite this, the differences in terms of incidence and mortality are not important. So looks like the data is clear. And I don't remember who said, I think it was Peter, with one graphic that the restaurants are not the primary source of infection. Here in Spain, the highest rates are in homes, private parties, families, and friends. So let's think about it. Next one, please. And what changes have we made or have we suffered in this?
Paloma,
yes.
A second, please. I think we have a problem with the presentation. So let me just fix it
yeah.
in a second, because I think I lost some of your slides.
Yes.
So let me go here. Sorry about that. And I will just click that very fast. Here we are.
Yeah.
Here you are, Paloma.
And thank you, Jaime. The principal problems is that the community of Madrid canceled the primary care assistance. So that led to an increase in the workload of the emergency services. And in some cases, even the saturation of them. And other problems we faced were that people were dying for COVID at home with no medical assistance. The hospitals were saturated, and people with other diseases didn't want to go to the hospital. And there were increased deaths from other pathologies like stroke or coronary heart disease. Next one, please. And as Yves has said, all the ICUs were saturated, and the alarm state allowed to nationalize all the private hospitals so they could transfer patients to them. And the severe intubated patients were transferred by the EM system to other ICUs. We transferred about 196 severe intubated, and with no increase like as it looks in mortality or hospital stay time. And other patients with less severity were transferred by basic life support units. Next one. And some important changes we have in our day-to-day is first one, the use of PPE from the beginning has been a major issue. Although at the first we were quite unsure, quite uncomfortable, they still are uncomfortable and stressing. We put, and we are using, this is terrible, but it's as it is, the use of the face mask 24 hours a day, 7 days a week, 365 days per year, in the headquarters, in the operational bases, in the rest area, in the ambulance. It's mandatory for all, still now when we are all vaccinated, to use it. We have to use surgical ones when we are not attending patients, and FFP2 or FFP3 when we are attending patients. It looks like this measure, it's going to live with us from now, at least in the EMS service, I think. The face shields, I have to say before the pandemic, I didn't want to use face shields, Google's protection, Google's anything, and they were really terrible for us because they are very uncomfortable. But since the pandemic, it's also another safety measure we have to wear, and probably we will continue using it from now on. And the ventilated hoods, that they are really useful. We will talk about it later with new technologies. Next one, please. And no, the previous one. that one. Thank you. Now we are not using PP type 1, we are using the gun. It gave us time saving and comfort, although at the beginning we were reluctant to use them because we thought they maybe weren't so safe as the PP, but now we are using it in every patient we attend, and surely we will keep it from long. And the disinfection circuits for the workers at our headquarters, and mobile teams that decontaminate the teams after having acted in homes or public places. And our workers now disinfect the surfaces, wheel, doors, handrails, chairs of the ambulance at the beginning of the shift and between every patient. Before, I don't know if you did it, but we had never done such thing. We get to the shift, we get on to the ambulance, we assumed it was clean, and that was all. But now we have these measures that with some luck, this one, we will maintain it forever. And finally, all these things we weren't used to do before the pandemic and are now in our everyday job. So we have to be aware of the importance of these strict measures. At the beginning, because of the lack of practice, it was quite difficult, but now, a year after, all the workers follow strictly and perfectly these severe measures. Next one. And one thing we were thinking when we were preparing this presentation is we had the doubt that if all these safety measures could have prolonged our response time. So we did take a look, and the graphic shows that the response time, this is from the moment the team receives the emergency call from the dispatch center until they get to the patient. And despite all the self-protection measures carried out to assist the patient, the response time has not been increased. So this is a good notice, good news. And last one, please. And some new technologies we have implemented in the pandemic, like the lung ultrasound. We did made a webinar before. Our COVID-19 portable antigen analysis, with sensitivity and specificity above 99%, that in 12 minutes we can know if the patient is COVID positive or not. And the ventilated hood I previously talked about, that provides greater safety and comfort. In patients, we have to isolate the airway. This one is not a mandatory PPE and a mandatory thing, but if they want, they can pick it up at the beginning of the shift and they can use it all along the shift. So it's a good thing to have them. And that's all from Madrid. Thank you very much.
Thank you very much, Paloma. I think that is extremely important because it has to do a lot with the trust of the personnel. And I think that this is one of our greatest challenges, to convince people that we are still protecting them, even though the very heavy PPE we were using at the beginning is no longer necessary. So thank you for that. As you understood, we had a little technical problem, so I will very fast run. Don't look at the slides, so they are a surprise, and we will immediately go over to Roberta from Italy. A second.
Here we are.
Roberta, please.
Thank you.
Thank you very much for being with us today.
Thank you. So next slide. I think that presentation is already done. Thank you. So I'm going to talk a bit with you about Italy. You know that here I'm bringing some graph just to make a confrontation with our closest countries, and you see that actually the waves are going a bit scattered in Europe, so not all together. In particular, I'm pointing the attention to the end of the first wave, when we thought it was terrible and it was ended, and indeed in Italy, the result was lasting longer than in other countries. So we were thinking to be better than the others, and indeed the WHO made a video saying, okay, Italy is very good, it's out of the pandemic, and so on. And then we paid very, very hard what happened afterwards. And this was because during the summer, we opened everything. And what I must say, and contrary to this, to what Paloma said before, is that indeed during the first wave we made a very strict lockdown, and it worked very well. And we went to the zero. Next slide, please. And here you can see, as Yves said before, that now we are not at zero at all. Neither after the second wave nor at the end of the third wave. Neither. Now the situation is a bit better in these last days, but very far from being zero. And so we don't know what is going to happen in the future. Next slide. Thank you. An important issue as well is the RT index. Now we are in this situation, so very close to our friends from UK, and we hope that that is a good news. But and of course our government, and in particular some party of our government, you know that we have changed the government very recently, and so the government composition is very differentiated, is pushing a lot to reopen everything. And we agree, and we are pretty convinced that the major problem is cited in gatherings, so at homes, in private gatherings, and so on. But we see also in the cities many people that are around the squares, the restaurants, etc., staying there for hours and so on without a mask and so on. So we are a bit worried indeed on the opening that now are going to be here next week. Indeed. Next slide. Just a few words, not much about death. Again, our death rate is varying, but again, we never reached the zero. And even if the contagion rate is going down, the number of deaths per day is still very high, higher than other countries. So, of course, this is something that we need to take into account. Fortunately, the number of deaths is mainly related to older people, because you know that Italy is quite an old population, but it is still very high. Next slide. Thank you. So, what different from the second wave? This is the second wave, and this is the third wave. That indeed, this is in orange is the number of patients admitted in normal wards. In red, the number of patients admitted in intensive care units. And what is true is that the number of patients admitted in intensive care unit is similar to the second wave and is lower than the first wave. So we had less very sick patients, so a lot of death, less than the first wave, but less very sick patients. The number of beds, of normal beds, also was a bit lower in the third wave rather than in the second wave. And this is interesting because maybe it rises on the fact that the public health system and the primary care system has been reinforced. So we have more doctors, more nurses that are going at home to the patients to see them. And so we see a bit less patient in the hospital. On the other hand, next slide, please. You see Italy is made of 20 regions. Each region has its healthcare government. It is not completely autonomous, but a good degree of autonomy. And you see that the situation is pretty different from one region to the other. This is the average of Italy. These are the cases, positive cases per 100,000 inhabitants. I'm living here in this region, Piemonte region, and we are quite in a good position, I can say. Now I'm working in the emergency department, and I'm presenting the data that our region, our regional crisis unit, this is made by us actually, some data that we gathered with collected in our emergency department. Next slide. And what I would like to show you is something quite interesting. Here you see that the total patients in all the of the region, that are about 25 emergency departments. Here in red, the COVID patients, and here in blue, the non-COVID patients. And what you see that during the first, this is the second wave actually. The second wave, you see that the non-COVID patients were much lower. During the third wave, what we saw was an increase and not a decrease of normal patients, an increase of COVID, but also an increase of non-COVID. And so it means that our job and our engagement was even higher than before, because another important point is that during the first wave, so 1 year ago, all the sick patients, so stroke, cardiac attack, cancers, etc., people that had to be operated were not coming for many months. And now we are seeing very, very, very sick patients that did not have a follow-up and so on. And so really very sick, a lot of patients to be admitted in the hospital. Next slide, please. And in fact, these are the figures about boarding. So you see that the boarding of non-COVID and COVID during the waves, here you had a decrease, a clear decrease in the non-COVID patient to be admitted. But here during the third wave, you have similar numbers of COVID and non-COVID. Now we are here, and so the COVID patients are not are much less than before. So of course, this is a moment that is not bad for us indeed. But this was a moment where we had really a lot of patients that were waiting for a bed. Maybe in some places they were waiting just for a few hours, but in some hospitals they were waiting for 1 or 2 or more days. Next slide. So our crisis unit took the boarding of the emergency department as a quality indicator, so to point out those hospitals that were working well at a good number of beds, a good flow of patients from inside to outside and so on, and as a process indicator, and also as an indicator to see, to prevent, to preview the next wave. Next slide.
Roberta, 3 minutes, please.
Yeah. I'm going very quickly. This can be skipped. Next slide. Just to point out that here is according to our red zone. So the lockdown here, lockdown national, lockdown here. And you see that after a few weeks, 2-3 weeks, we had to, we had the decrease in cases. Next slide. This can be skipped. The important message is that what we learned, that this is the lesson learned, that the outcome of the patient and also the length of stay in hospital was according to the aggressivity in treatment of patients. So many patients were treated early directly in the emergency department, waiting for a bed, but they were treated with ventilation. We used a lot of CPAP, and this is what was one of the reasons that we had to use less ICU beds. And early treatment, medical treatment, and observation. Sometimes with the observation of the patient and treatment, early treatment, we could observe the patient for a couple of days and then send them home directly without hospitalization. Next slide. As regards vaccines, we're starting very well, but now we are a bit behind the rest of Europe. We are one of the last, but in any case, we are on, next slide, we are almost at the same point because as Yves said, we are around 20% of our population that is vaccinated at the moment, so not yet enough to open everything again. Next slide. The effect of vaccines that we are already observing is that the elderly from nursing home that are almost all vaccinated are not coming anymore. That the cases among healthcare personnel is reduced by 98%. I heard about burnout. At the moment, we are keeping and not staying in sick leave for burnout at the moment. And the reduced hospitalization and mortality. Next slide. The pitfall, this is my last line. We had, as I told you already, we have a lot of political interference, pressure to open and so on, and so we are trying to resist. Social burden, because you know that there are a lot of protests in the streets from restaurants and so on. Infodemia, this is a big problem. I don't know in the other countries, but we have everyone that are expert in COVID, vaccination and whatever. So there is a problem also on the trust on vaccines and so on. And fake news and misinformation. Next, actually the last is this one. So what to expect? The politician promising that everything will go better and better. The virologists are quite pessimistic. The epidemiologists and the statistics that have the counts are definitely pessimistic, and the clinicians are resigned to the battle. Thank you very much for your attention.
Thank you very, very much. I think that this slide we should put as a poster. I think that's a global truth for everyone. And yes, at the end of the day, we are the front line of the battle. So thank you so much.
Thank you. Thank you.
And our last speaker of today is Dr. Jorge Morales Alvarez from Emergencies Medic de Catalunya. Por favor.
Thanks. Good afternoon, and thanks for your invitation. I think so. This is the great moment for the thing. What happened in 1 year? Where is the real situation and the real point of care, the state of art, the emergency system? What happened? What we done in this year? The next, please. Well, the perspective to the emergency medical system in Catalonia responds to the first response to every emergency to approximately 8 million people. We have 7 health regions in the area similar to Belgium. So next, please. Before the pandemic, in the order to health system respond, we have 3 levels: the hospitals and level 1. The proximity hospitals is now critical care units, and the level 2 has the critical care units, and high-tech hospitals with the have the specialist critical care units. Total critical care beds in the system before the COVID around 615 structural beds, and the chronic and the sociosanitary nurseries for the chronic patients, it's around the 8,000. We have the system around 413 ambulance in different categories: the basic life support, advanced life support with the medical or physicians, and the around to 15 ambulance with only the nurse and technicians. Well, the first point is the adaptation to demand the new services. For example, we adapted the system with go in the home, the patients, in the contacts, and test PCR test prior to the epidemic fast declaration. But I know this the political decision is not the technical decision, but the change of the emergency systems, it's really important. The next, please. The first big shock in our system is the calls received in the first wave. You looked in the blue bars. We received in total calls in one day more than 40,000 calls. The system is no support the demand. We changed the more lines for attending people. It is really important because the most important it's the fear. The people call on the emergency system with fear. And you look the different walls, the 1, 2, and 3 wall, the high activity, it's in the most concentrated cases of the COVID. And related to the change, the political decisions and the different points of view of the fake news and the others. But you look in the red, real COVID cases, confirmed cases. And red is very important because it's the only one window to the health system in Catalonia. On the next, please. Well, the adapted formation were 400 teleoperators and 200 healthcare professionals, 50 nursing and 20 physicians, and we need the 3 call centers close to the 3 normal call centers in Catalonia. We have 3 emergency coordination centers, and we need the 3 space only 100% dedicated to the COVID response. Next, please. Well, it is really important to support the different hospital structure because the great pressure to the health system is very high. The same to the different countries and the different regions, and especially to the first wave. We had 20,000 people in the hospitals, and around the 1,600 people in the critical care unit in the first time. We need the change the organization because need the redefinition flows, the pathology, no COVID, pediatricians, and high priorities program, and assistant procedural support, access to 24/7 days home care system on the 061. It's the numbers of 61, the national number for the access on the health public system. Next, please. Well, we changed to the emergency logistics services to the public health system. We take the different equipment to electromedicine, especially respiratory therapies, and we create the two different web service for the health system, and the response, the demand to the different electromedicine in the hospitals, especially in the second level and the proximity hospitals. The next, please.
Jorge, 3 more minutes, please.
Yeah. Well, there's a change to different space. Next. Well, the real impact in the public health system in the April last year, we have 116 patients with COVID in the critical care unit. It's 3 times more to the normal capacity in the critical care units in Catalonia, and non-COVID plus 400 patients with a normal pathology, which is 2,100 patients in total in the one world. Next, please. Well, the great problem is the transfer inter hospitals. On the next, and with the sign of the crisis cabinet with the clusters in 5 high-tech hospitals, support the next the other hospitals are little hospitals, but if the brain of the system is the emergency medical systems, it is the coordination and the specific table to the inter-hospital transfers, and 1 critical care physician 24/7 days a week. Preferably to transfer in the same level of the critical care unit, but it's possible that patients need complex therapies with the ECMO, for example, and flows in the vertical and horizontal flows. Next, I think so. 2 more. Well, this in normal day we have medium 100 inter-hospital transfer in Catalonia. Well, the 3 walls you look in the critical occupation, this is 100 to 1,200 patients 3 months, the last 3 months, and you look the different inter-hospitals transfers in Catalonia. Next, we create the complex critical care program, one total around 300 patients, different devices, for example, the ECMO in this year 65, and Impala and the others supports, and the global mortality discharge to the hospital. This program, the critical care complex program, it's around the 30%. The mortality in the critical care units, it's around the 22%. Obviously, this patient is the more complex and need the most technology. The next. With this program, they reduce the time, the transfer, the different transfer into hospital in 3 hours. The medium activity received the call, we have the hospital. It's 3 hours and maximum 3 days in the first wall. In the second and 3 walls, reduce 1 hour the confirm the final destiny to the patients. The next.
We are really running out of time, please.
Yes. that's the same of the reduce the high priority activity of STEMI, stroke, and trauma. The next, I think so, is the last one. Well, we work in nursing homes. And the last slide, please. We have the fear management with the psychologist in the program in the emergency system. I think so too. The different apps to fear all the contexts. I think so. That's all. Thank you very much. It's really interesting, the different changes in the system.
Thank you very much. I think that the issue of fear management is something that we are overlooking, and it's critical, and it I'm sure is associated with also burnout. So before concluding, I would invite you already. I sent you a save the date for May 13th webinar, which will be organized by our friend from Samur, Madrid, on going back a little bit to the routine activities on EMS operations in civil unrest or urban riots, if you want to call it like that. I think a great challenge for all of us. And I would finalize by thanking you all for participating, calling you to get the vaccine, use the mask, avoid public gatherings, and maintain social distancing. This is the word hope in Hebrew, and hope this year is associated with these vials of the vaccine. So please take good care of yourself, of your team, and yours, and see you around. Thank you so much for attending this webinar.